Okay, so apparently it's time for us to start since everyone got quiet. So I'm Chris Wildeman. I'm director of the Bronson-Renner Center for Translational Research. I hear that I asked many of you for gift cards today through a spam attack thing. So if you did send them, I actually really appreciate it because I could use them. Anyway, I'm really sorry if you did get those, and apparently it responded in like a somewhat curt way, in the same way that I do, and so people got sucked in by how impolite the message was. So seems to make you feel good about yourself. Anyway, I'm introducing Emily Wang today, who's our speaker. I'm not allowed to give a long bio thing, apparently, but I've known Emily for about 10 years. I think of her as being sort of a truly transformational kind of figure in terms of both doing sort of the highest quality medical research, providing really exceptional care to historically marginalized populations, and then also bridging researchers across a bunch of domains. So Emily's great. Yeah, and welcome. Thanks for coming.
Thank
Sure.
you. So it's really a deep pleasure to be here with you guys today. It's been a long time since I've been in Cornell. And I will say it's just a real pleasure to be kind of back at Cornell with Chris, a longtime friend and collaborator. It's one of these things that I think as you get older in life, you realize that some of the best partnerships you have in research are those outside your field, really pushing and challenging you to do that. And so it's with that spirit I come here to share a little bit of the work that we're doing both in the clinical space as well as science, and especially and importantly in partnership with people with histories of incarceration. Chris has alluded to the fact that I am a primary care physician and practicing. My practice consists only of seeing people that have just been recently released from corrections. And I've also worked to bridge the work that we do in clinic and bring it into really thinking about how it impacts science. And it's this intersection, thinking about how incarceration impacts patient health at the individual level, family health, and community health that have really undergirded the work that we've endeavored.
Don't worry about it, it's just people join you.
We can call it a day, that was great. So, I will say that, in the last 10 years that I've been doing this work, we really are living in an unprecedented time. There's bipartisan support for criminal justice reform, and in much of the political advocacy that's going on and the science and kind of a more solutions-oriented framework of even thinking about decarceration, I think that there rarely or is a rare authentic representation of people with histories of incarceration equally at the table. And so it's this piece that I want to share with you about our work. It's how we've thought about including people with histories of incarceration in clinical care transformation as well as scientific transformation. I feel very comfortable having a real frank conversation about this, the real challenges and opportunities of doing so. But I want to, if there's one thing you leave, just walk away and walk away from this talk, is just the singular point is that I think it's critical that each and every one of you as scientists really engage in thinking about how it is in your own practice to really bring in people with kind of lived experiences with incarceration into your work. So I'll start with a background and touch on kind of the impacts of incarceration on health risks, speak a little bit about how we've included people with histories of incarceration into health system transformation, and talk a little bit of the work that we've done in the Transitions Clinic Network. I'll provide probably two quick examples, if time permits, of how we've included people with histories of incarceration in research, and then end with some concluding thoughts. All right, so just to make sure we're all on the same page, and this, probably comes as not a big surprise to most folks in the room, but there are about 7 million people that are currently under the jurisdiction of the criminal justice system. The correctional population has tripled in the past 25 years, and there are a number of reasons that are espoused behind kind of this really tremendous growth. This includes mandatory sentencing policies, the war on drugs, the institutionalization of mentally ill. It's obviously a complex issue, but it's really spiraled out of control in the last 3 decades. And just to make sure that we're in the same page also about in terms of terminology, so there are about 2.2 million people at any given point in time held behind bars. So when you break that down, they're in jails and prisons. Jails typically house those that are awaiting adjudication of crimes, so people that haven't been sentenced, or people that have been sentenced and serving sentences of less than a year's time. Prisons house those that have been sentenced for a crime, typically serving sentences of greater than a year. So 2.2, and again, more people are held at any given point in time in prisons, but the throughput, the in and out of jails is far larger. Frankly, it's actually not well estimated, and it moves from any, because it's not well calculated, we don't have a real denominator, about 7 million to 10 million. So big throughput in any given year. The majority of people that are under kind of criminal justice systems are living in the community. So it's about 4.4 million that are in the community. The majority are in probation, so that's people that have been convicted of a crime, serving their sentences in the community, and then people on parole. So those are people that have been convicted of a crime, served some portion of their time behind bars in prison, and then released back into the community. All told, again, the estimates aren't great, but there are about 63 million Americans that have a criminal record. And so U.S. incarcerates more people than any country in the world. This figure comes from Chris and I's paper in the Lancet, which just shows the U.S. and it's on the tippy top upper left-hand corner in contrast to 20 developed democracies. And so, it's just meant to say that, I recently had the opportunity to go to Finland and was part of the World Health Organization's technical expert group on health and prisons. And there, when you talk to the Finnish government, they are astounded by the rates of incarceration in their country. And then just in contrast, they're in the upper right-hand corner. So you can barely see a tip, and that there is a huge aberration.
We're having trouble hearing you, so we're going to put you on a mic.
Okay.
We're just going to break for 1 second.
We can hear you, but you have to really listen, so, which is not bad, but.
I'll take it.
Okay, can you hear me?
Oh, much better.
Good to know. This is getting older, maybe. So, all right. So, and then what we also know is that those who are incarcerated are disproportionately poor men of color. These data are outdated, but I like the infographic, and frankly, it's been repeated subsequently, and the data are just about the same. So these are using life table measurements. The data come from 2003. But what we found was that about 1 out of 9 men in this country have a lifetime likelihood of being imprisoned. And again, these data only come from data around being incarcerated in a prison. They don't accommodate for those who are in jail. So you can imagine that this is a far higher an underestimate of those that have actually been incarcerated. When you look at Black, white, and ethnic disparities in incarceration, again, for white men, 1 in 17 have a risk of imprisonment. Black men, you have a 1 in 3 risk of being imprisoned in this country. It's a 1 in 3, so it's astounding. And again, when you break it down by socioeconomic status, it's even more astounding. Latino men, 1 in 6. Women are less likely to be incarcerated, but again, you can see that among women, there's a disproportionate incarceration, again, for women of color. And so, with this and with the scale, you can imagine that given kind of the disproportionate incarceration of racial and ethnic minorities and also of people of low socioeconomic status, that there might be kind of increased health risks in this population. And I often get asked this question of how are people who are incarcerated, how are they any different than poor folks in this country, homeless folks, people with substance use disorders, people with mental health illness. I also get asked the same question by researchers, kind of in a more snarky tone, like this issue of causality. Is there a real independent effect of incarceration? And, I've come to this more Zen part of my thinking around this is that we probably will never know. You know, randomization to incarceration is a little bit ridiculous. And so what I am going to do is just show you pictures of people that have been incarcerated. I had a longitudinal primary care clinic in San Quentin, which is one of the largest, oldest prisons outside San Francisco in California. It had a population of about 1,000 people on life without parole, 1,000 people that were serving sentences for the death penalty. And just by state validity alone, you try to make the argument that incarceration indeed is a unique experience that impacts patient health. And then I'll share with you some observational data that our team has done trying to expound upon that argument. So this first picture, again, is just to show that people behind bars are aging. And in fact, oftentimes the media gives us the impression that the folks inside are this young, healthy lot. They're out there exercising. They're living kind of this great, energetic, enthused life. And in fact, 80% of individuals who are incarcerated have a chronic medical condition that warrants longitudinal primary care. And what this includes, of course, are things that, substance use disorders in the press these days, opioid use disorder, alcohol use disorder. It also includes depression, PTSD, mental health conditions, but it also includes things like asthma, diabetes, hypertension. So about 80% have a chronic health condition that warrants longitudinal primary care. Just in this picture, I just want you to see this guy is waiting to see a doctor right now. And you can see that the man next to him also is waiting to see a doctor, but he's held in a cage. And so this is his experience of seeing and accessing health care behind bars. One of the things that drew me to this work initially is that healthcare is constitutionally guaranteed in prison. And prior to the Affordable Care Act, it was one of the only places in the U.S. where there is a constitutional guarantee of care. And so what this means is for this population of mostly poor folks and disproportionately racial ethnic minority groups, it often is their first experience engaging the healthcare system as an adult. What we and others have found is that about 40% of individuals, when incarcerated, are actually newly diagnosed with a chronic medical condition. And so this is where they're first learning to engage the healthcare system. I shared this picture. So this is a patient that was newly diagnosed with high blood pressure, hypertension. He had hypertension that was so extreme, called hypertensive emergency, that he had to be sent out to the hospital. So, you can present with stroke, a heart attack, immediate vision loss. And so he'd been diagnosed while incarcerated, sent out to the emergency department in the hospital, and then was returning kind of post hospitalization. And what you can see here is that these are daily rounds. Okay, so you'll note that there's no set-aside clinic for us. There's no place for him to convalesce. He's in a cell. Any of you have ever visited a doctor, you can note that this is rarely how you're checked. Your blood pressure is checked throughout, kind of the blood pressure cuff through the window, the man straps it on. Our conversation is in full public view in front of the other patients, the individual that's incarcerated beside him, as well as in front of the correctional officers. And so there isn't this confidential space to have this heart-to-heart patient-doctor relationship. The second is that every morning this patient is woken up at the crack of dawn by a correctional officer, asked to make a line, a med line, and he's getting 3 new medications. So to kind of control his high blood pressure, 3 medications that aren't particularly divertible, they don't have a real market value. He's asked to dump it out. The nurse gives it to him. He has to take it, give it a cup of water. He swallows it. She checks to see if he's cheeked it, and then he moves back into his cell. And so adherence is almost 100%, but it's incredibly passive. You don't have to go to the pharmacy, you don't have to think about it, you don't have to think about when you're going to eat, you don't have an option of choosing when and how you're going to take your blood pressure medication. It's when you're called, you make the line, and you get your meds. Patients that are diagnosed with diabetes that require insulin, they never once get the opportunity to pull up and draw up their insulin syringe. They don't have the opportunity to use a glucometer. Everything is done for you. And so again, really passive. And in some settings, if you don't, especially if you require insulin, in some settings, if you say, not today, I don't feel well, or I just don't want it for whatever reason, people, patients of ours, and in studies we've documented, that actually get sent to solitary for not complying with kind of the medical regimen. And so you can again see that its adherence is almost 100%, and it's incredibly passive, and the management of a chronic condition is really punitive at times. And then, again, while there is a constitutional guarantee, access can be quite limited, and limited in particular by institutional policies that are, in some places, structurally violent. So this picture I share here, just turn your attention to that pink slip. That's called a kite, and at the time in California, people that are incarcerated have to fill that out to see a doctor, okay? That slip was then evaluated by a correctional officer. If the correctional officer felt that there was medical necessity, then the nurse would evaluate. If the nurse felt like there was medical necessity, then a physician would see it. And so you can see that the whole kind of experience of healthcare is meted out through the correctional system that has really different priorities than how traditional health systems would be designed. The other thing kind of to note is that for patients to see a doctor when they're incarcerated in most states, they often, for instance, in Connecticut, where I'm living now, you have to pay $3 to see a doctor. So there's a co-payment. Okay, so $3 a co-payment. How does that sound? Pretty regular here in the community, right? So excuse me?
Depends on what you got on the books.
Yes, you got it. That's exactly right. So, $3 to see a doctor is equivalent, if you're lucky enough in Connecticut, to 4 days pay. So people that have a job, and the majority don't have a job, make 75 cents a day. And so again, you can see that, think about that patient that was just newly diagnosed with high blood pressure. He, let's say, many patients do develop a side effect right after starting medication, wants to see the doctor. You've got to pony up $3 to see the doctor when you want to kind of talk to a doctor about a pressing health condition. And so this is exactly right, is that while there's a constitutional guarantee and while there is access, and that's important, again, 40% of newly diagnosed, there is this increase in the ability to get health care, and it speaks probably more to what we're able to give people in the community, but there are all sorts of caveats. And then, I remind folks that the conditions of confinement really do impact disease management. And so, again, this is a patient that was incarcerated in San Quentin that for years had been held in solitary confinement. So 23 hours in an 8-by-6-foot cell, where his only outlook was that window there, and could come out of that cell an hour a day. And what you'll note is that he's a gentleman with COPD, oxygen dependent, and would require that oxygen. And minutes, every hour, you would hear bamming on the cell. And inevitably, the tubing is kinked. And so, you can't help but imagine that if this is your experience, both either practicing as a physician, but more importantly as a patient, that you would, one, mistrust the healthcare system, and two, hopefully making the argument that your health and your interaction with the health system is inevitably impacted by having been incarcerated. And then, I get asked those questions like, well, this is all good, Emily, but this has to do with the whole healthcare system behind bars. What does this have to do with, us in Yale New Haven Hospital? And what I'd like to remind people is that 95% of individuals who are incarcerated will actually come home into our community health systems and live among us. And so the issues that affect those who are incarcerated and the healthcare system behind bars inevitably has implications for our community. When people come home, for those of you that have been hospitalized or loved ones have been hospitalized, like even if you spend like 24 hours in the hospital, typically your meds have been sent to your pharmacy, you've got your medical records, you have a primary care appointment all set up. In fact, those are federal regulations that have to happen to make sure that there's a transition of care. For these millions of individuals who are incarcerated, there are no federal regulations that kind of oversee their transition back into the community. And so there's minimal to no discharge planning. And what this means is that in Connecticut, which is probably one of the better discharge planning states, about 30, you get 30 days worth of medication. Okay, so not terrible, but it's just 30 days in a time that's really chaotic, no primary care visits, and then certainly no medical records. But again, in most states across the board, there just isn't systematic planning. Most states, unfortunately, the majority, 30 states have, actually it's probably 36 now, have expanded Medicaid under the Affordable Care Act. And so it means newly that people, young men without kids, probably in these states with expanded Medicaid, have newly been enrolled in Medicaid through the expansion under the Affordable Care Act. However, most states still terminate Medicaid when people are incarcerated. And so even in expansion states, you'll often have situations where people are eligible for Medicaid as soon as they're incarcerated. Those benefits are turned off, and then when they're released back home to the community, they have to reinitiate the Medicaid. And so there's real barriers in healthcare coverage, insurance coverage, post-release. And then lastly, most are released without resources in their pocket, and then there are additional barriers to meeting your basic needs. So getting food, there's, depending on what state you live in, still bans on, lifetime bans on getting food stamps in one state if you've ever been convicted of a drug felony, additional barriers to getting housing, looking at what in Section 8 housing, as well as barriers, of course, in employment and education. So all told, the transition home is difficult. And what we wanted to do, we tried to do, is study how that impacts health outcomes. And so in this first study, I'm going to do a quick check on that. In this first study, what we looked at was how incarceration independently puts people at risk for developing hypertension. And we took data from one of the only cohort studies that actually measures blood pressure as well as cardiovascular risk factors over time. It's the cardiac study. They followed 5,000 young adults over now 30 years, and wonderfully have two measures at baseline and then at year 2, which capture incarceration exposure in early adulthood, and then followed people and found that among those that had a history of incarceration in their early years, they were more likely to have a higher systolic blood pressure as well as develop instant hypertension 5 years after their incarceration exposure, even after adjusting for clinical risk factors and sociodemographics. What you can see here is that we found this association again among all participants, and then also among the subgroups that are more likely to be incarcerated, Black men and less educated folks. We didn't see it in the other subgroups, and in particular, you can see the confidence intervals were quite wide, and we just didn't have a lot of incarceration events. We've also used data from, again, the Veterans Aging Cohort Study, again, a cohort study where they measured incarceration history among 6,000 individuals, and then also have clinically measured blood pressure outcomes, and then pharmacy database validated hypertension outcomes, et cetera. And what we wanted to do in this study was to study whether incarceration exposure, recent incarceration exposure, is associated with worse control of hypertension outcomes. And if you turn your attention just in the fully adjusted model, found that among those that were recently incarcerated, again, even after adjusting for all the covariates that we know are both associated with incarceration as well as poorly controlled hypertension, we still found a pretty substantial association and increased odds of uncontrolled hypertension among those that experienced recent incarceration as compared to those that were never incarcerated. In this study, because again, the VA database is so robust, we're able to get all the pharmacy records for these 6,000 individuals. And so we wanted to see whether or not having access to hypertension treatment was driving kind of this outcome. We hypothesized that maybe those that have been incarcerated couldn't get their meds for whatever reason, didn't know how to get their meds, and in fact found that that wasn't the case, that people were not more likely to have hypertension treatment or less likely to have hypertension treatment. So that's not what's driving the outcome. And then lastly, we've looked at data from Medicare administrative claims data and are really trying to tease in to whether or not this, again, period of release is associated with increased hospitalization risk and increased death. And so Medicare, just to make sure we're all on the same page, is a federal benefit for those over 65, people with end-stage renal disease, or people that are identified as being disabled. Again, so it's a limited cohort where we have this data. But what we were able to do is identify those within Medicare, and I can go into that a little bit if anyone's interested later, within Medicare, and then identify a matched control comparison group that was matched on age, gender, race, and zip code, and then reasons for Medicare eligibility. And so just to orient you to this, the top figure is hospitalization, and then the bottom figure is mortality. The light blue are the never incarcerated, and then the black is the group that's been recently released. And what you can see here is that there was an increased time to hospitalization and an increased time to death among those that were recently released, and in particular for conditions that are preventable, and including cardiovascular disease. So we're really focused in on this. And so I want to highlight two kind of big things here, is that there aren't a lot of places where you can find robust studies to both measure incarceration and, clinically reported or kind of physiologic measures of chronic conditions like high blood pressure, like diabetes. And so it's important, where they exist, and especially if you're designing studies, to think about how you can better measure these. But there are opportunities within administrative data to really push forward and look at this. And so what are the kind of common causes of death post-release? So I point to Ingrid Zinswanger's study published in the New England Journal, kind of the seminal study that was published in 2007, where she took all individuals that were released from Washington State, again, compared it to an age, gender, and race matched comparator group, and found that there was about a 12 times increased risk of dying in the first 2 weeks post-release. And then, this actually shows the risk of dying within a year. But you can see that the number one cause of death is overdose, then heart disease, homicide, suicide, and cancer. And so much of these conditions are readily preventable with engagement, routine engagement in primary care. And so, when I first got started in this as a resident, I kind of just felt like all this information was incredibly frustrating, it's irritating, it looks at real, it highlights real inefficiencies in the healthcare system, and it seems like there's got to be this easy fix right at the transition, right? That right at that transition feels like the place to kind of hone in. And some of what I've learned over time is that, one, when you think that there's an easy fix, it really isn't all that easy. But secondly, that especially when it comes to these complex issues, that engaging people with histories of incarceration, the people that are most impacted, has to be priority, especially when thinking about intervention design. And so it's with that energy that about 10 years ago we started the Transitions Clinic program. The first program is in San Francisco. This is a picture of Ron Sanders, a community health worker who's been incarcerated with one of our patients. And in San Francisco, given a real robust network of formerly incarcerated individuals, civil rights activists, started kind of community conversations of what would it take, what do the programs look like if we're really going to just try to first tackle what seems like an easy lift, that transition back home. And so it was in those conversations that we started thinking about how it is that you shift the paradigm of primary care. And so instead of this gentleman coming home, released, not knowing how to use the healthcare system, again, unable to meet his basic needs, the first person you would meet, ideally prior to release, is a community health worker. And so this top picture up there on the right is Juanita Alvarado. She's been incarcerated. She likely would have met the patient while incarcerated, and so I'm going to be your first contact when you come home. I've been incarcerated. I've actually been really successful coming home and staying out. And I know it's going to be difficult. Here's my number. We're going to get you an appointment. Juanita would be a guide who's trying to help the patient prioritize both the healthcare needs as well as kind of the social or emotional needs that the patient would have. Oftentimes, a lot of what's needed is just guidance through getting an ID. getting kind of government identification to be able to then get kind of what you need to get housing. And so whatever the patient's needs are, whatever the patient's priorities are what our community health workers charged with. Then we would see Levis, the bottom left, within primary care within 2 weeks. And in that visit, there would be a frank acknowledgement. We would know that, one, there's a healthcare system behind bars. Most primary care providers have no idea that there's a healthcare system behind bars. And so it would be a space we'd say, look, we know there's a lot going on in your life. We welcome you home. We're going to help you to at least get your meds back in order, try to get your medical records. What can we do for you here today? Over time, we'll screen you for the health conditions that are more common among people with histories of incarceration. And then even more over time, we're going to come up with a plan of how to prevent you from going back inside. We contend that that's one of the least healthy exposures, and so we can talk actively about it with the primary care team and with Juanita, the community health worker, as a team. And then lastly, the clinic kind of extends outside and starts attending to, what's commonly talked about nowadays, the social determinants of health: food, employment, housing, civil legal needs, anything that really impacts one's health, and we really broadly define kind of health. So some of it is about having a healthcare provider that can screen you, et cetera, and then much of it has nothing to do with a healthcare provider that can screen you for chronic conditions, and all of it really kind of fits with what Juanita does in partnership with local community organizations. And so sure enough came the time that the program had started going. One of the things that we felt certain about is that we didn't want to start a program that had really been built upon community engagement and then did not continue that thread. And so convened the community advisory board, the majority of whom were people with histories of incarceration. And so our kind of key partners in this are All of Us or None. It's a national organization that's worked on huge civil rights issues, including employment discrimination based on criminal record, as well as getting off the road. Legal services for prisoners with children. Our own patients were involved, neighborhood residents, and then importantly, we involved many city stakeholders and leaders, even at the state level, in the conversation of what's going on in the clinic, how can we improve our services, and then how should we evaluate it. And so we were clear that we wanted to test the efficacy of this and use community-based participatory research approach in the framing of this. And for those of you who are not new or new to it, or even old to it, again, the definition that I draw on comes from Barbara Israel, which is essentially a collaborative approach to research that equitably involves all partners in the research process and recognizing the unique strengths that each brings. And so what it meant for us was that people with histories of incarceration, as well as other stakeholders, ultimately, were really involved in the first notions of how it is that we could design a study, do it ethically, do it meaningfully, and really use these data to sustain what we thought was a good and important first step in transforming primary care for people that return home from prison. And I'll say, over time, this has evolved. What does participatory budgeting mean? We can talk openly. We're like, oh, yeah, it's really participatory until it comes to the cash. And so I mean this is that not all projects use this approach in my own research team's kind of portfolio, but when we do, this is what we really kind of talk about. What does participatory, what does equity actually mean? And so we decided to design a randomized controlled trial. We feel like, our group really feels like, oftentimes it's not the ideal, it's not the best quality evidence that gets leveraged in studying people with histories of incarceration, and so they wanted the best quality of study to be designed to study the efficacy of this. And you can imagine that with all those folks at the table, what was complicated was that, well, prior to transitions, there was standard of care, which was nothing. There was no transition going on, and no one felt like that was ethical. And so what we designed was everyone would get a transitions clinic visit, a 2-week visit within transitions clinic, just to make sure their most urgent needs were taken care of. And then people were randomly assigned to either stay in care within transitions and get a 4-week follow-up visit within transitions, or get an expedited 4-week visit within the community safety net. And so, again, importantly, everyone is at the table. This study is designed probably to find a null finding because both arms are getting an intervention. And I think what was important is that there was lots of discussion about what the design implied, what it meant, and a mutual understanding that even if we found kind of a null effect, that there still might be value in a program like this. And then we also collectively chose study outcomes. And so, for me as a primary care provider, I can tell you that I'm not super jazzed about studies on healthcare utilization or any return to jail. In fact, I'm probably more interested in return to jail outcomes, mostly because that has a lot of meaning for patients. One less hour in a jail means a lot. Healthcare utilization, I don't know. But I can tell you the reason why we settled on this as a group is because everyone around the table knew that this was the path to sustaining a program like this financially. That the Department of Public Health was really interested in healthcare utilization. The public at large was really interested in return to jail. And so we agreed that for this first step, and it was a modest step at that, you'll see that these are the outcomes we'd be looking at. And so this study was published in American Journal of Public Health. We ended up randomizing 200 individuals. And what we found was that among those that were randomized to transition clinic compared to those that had an expedited visit within primary care, they had about 50% fewer ED visits in the 12 months following prison release, no difference in the return to jail, no difference in hospitalization rates. All right, and so this is about the effect size that you would see for most community health worker interventions. And it's with this, well, I guess so, some trade-offs here of using this took a lot of time. The amount of meetings that you had to have to kind of discuss through different study design options, picking out outcomes, consensus, was not easy to reach. There was really heated discussions about this. But the advantages of this were that we had really high participation rates. Like most studies that recruit people with histories of incarceration, our participation rate was, I think, 96.something%. As I mentioned before, our study results really wouldn't necessarily compromise kind of plans for continuing the program. It might have, but it may not have, because we spent so much time talking about what we would and wouldn't be able to find. And then it certainly enhanced the dissemination of our work. Since then, this program has grown to now 40 programs across the country. We've taken care of 6,000 patients leaving correctional facilities, and have been able to work in states like North Carolina. So the state of North Carolina, for instance, hasn't expanded Medicaid through the Affordable Care Act, but some of work that we recently published has shown that transitions clinic reduces time in jail, where we had a better data system to really look at jail stays. And it's in that Departments of Corrections are actually shifting their budgets into State Department of Public Health infrastructures. And so it's been this great opportunity in building the network and thinking about our research agenda that we've been able to push forward more programs, in particular now working with state governments and then large Medicaid managed care organizations. And so it's this that, I just wanted to focus in on, is that part of the real joy for me comes from working with a really vibrant and impactful group of people with histories of incarceration that are community health workers. This photo is our first cohort of 14 community health workers that was funded by one of the CMLI Healthcare Innovation Award grants. And, these are kind of the heart and soul of our intervention. We now have about 250 community health workers across the country. LA County alone is right now working on training an additional 200 people with histories of incarceration to really help transition the care of everyone that's returning home from LA County. And I think important, and why I pause here with this, is just to state that oftentimes the interventions that are focused on people that are justice involved are really about mitigating risk factors, about kind of identifying individual characteristics that are there, and that if we just kind of fix these bad apples, what would happen? And in fact, I think scientifically that's a flawed approach, that a lot of the solutions actually do come from identifying assets things that are working in communities, and actually studying, you know, in public health, it's called a positive deviance model of the things that work. What works? You know, in spite of all the kind of structural determinants, the barriers to health. There's lots of good going on, and so this is the real focus of our work. So our lab now is really focused on exactly that, of really thinking about how to prevent exposure to incarceration, to mitigate harm, and in particular, mitigate harm by improving the assets that exist in communities and improving health and well-being. And, you know, key among this is about 4 years ago, even within my own team right now, we have about 14 people, part of our, our team, are really committed to even bringing in people with histories of incarceration into our research team. So, and in that, a lot of the focus here is trying to bring kind of what we see in clinic back in to research. And so I'm going to, just looking cognizant of the time, and going to kind of breeze through this a little more quickly. But give you an example, one example of a small study that we did a few years back, where we've really been able to capitalize on the experience of caring for people in clinic, and then using that to build off a scientific question, again, using a CBTR approach. So I had a patient, a 26-year-old woman who's back in California, who had a past medical history of hepatitis C and intravenous drug use, who had just been released from prison, came to clinic, and was actually doing pretty well for a bit, and then had returned to sex work because she couldn't feed her kids. And she complained, in particular, California had one of these like modified food stamp bans where she had to participate in a certain amount of programs, a ton of programming, just to get her food stamps. And so, as many of you may know, many states still ban people with drug felonies from obtaining food stamps, and this can range from a lifetime ban. South Carolina is the only state now that has a lifetime ban to many modified bans. The Sentencing Project estimates that about 180,000 women and children are affected by this food stamp ban, and so it's one of many collateral consequences following release. And you know, what this patient did was brought up the question of what are the rates of food insecurity following release, and is food insecurity associated with HIV risk behaviors among people recently released from prison. What's interesting about this is that it's been studied, it has been studied a lot in developing countries. And we thought that this is an opportunity both to advance the science and also think about a more public health framework for understanding what might be the consequences of a food stamp ban for people that had just been released from prison. And so food insecurity is defined as limited or uncertain availability of nutritionally adequate food. It's, you know, insufficient quantity, insufficient quality, feeling anxious about getting food, feeling deprived about food, or inability to procure your food in a socially acceptable manner. And like I indicated, it's been in many developing countries, mostly in Botswana, are associated with HIV risk behaviors. And so, again, used the CBTR approach, convened our transitions clinic, our community advisory board, and in this project hired up people with histories of incarceration to help us design the survey and then implement the survey. And we wanted to do it in 3 states that had different food stamp bans. And so, you know, it pushes out on Yale's hiring practices around people with histories of incarceration. It pushed out on a lot of different institutional policies that I was pretty naive about when I first started at Yale, but it was an important and growing experience. And so what we did was use a validated measure, the USDA measure of food insecurity, and I'm not going to spend too much time on this, but I just will point out that if we hadn't have involved people with histories of incarceration from the beginning, then we wouldn't have realized that the way that the USDA measures food insecurity is just not applicable to people that have just been released from prison in so many different domains. Like I might have guessed, fine, their kids don't live with them, they're in group homes, but it really got to the place where when you're actually administering the survey, you know that many people go to halfway houses in Connecticut. So there's not food insecurity in a halfway house, but it's when they return back, leave the halfway house, that there is food insecurity. And so their inclusion is not just a feel good, it improves the science. Secondly, we use the outcome of, these are again using standard validated measures, the highest quality science that you can bring. And then again, even in conversations with them, which is that these aren't going to get an accurate measure of HIV risk behaviors given the timing. Many people in halfway houses, again, get urine tox daily. So if they get a urine tox, then obviously their drug use isn't going to be high in that time period. So you have to think about sampling different times. And so we administered the survey in 110 people, 3 different states. And kind of the first big finding that we had was about 91% of people that we surveyed, again, it was a convenient sample. So it was like a real pilot, just to see if we can even do this. 91% of people that we surveyed actually met federal guidelines for food insecurity. That's astronomically high. Typically, the rates in low-income families are around 30%, 40%. So it's 91% met federal guidelines for food insecurity. And so, of course, we couldn't fashion an analysis based on 91% of sample size. You can't distinguish the differences between 91% and the other 9%. And so what we found was that almost 40% went 24 hours without food in the past 30 days. So kind of that's the federal definition for going hungry in 30 days in a month. And so again, 40% went without food, and then the other 60% didn't go without food. And those that lived in, those that went hungry were more likely to live in the state with a SNAP ban. Those that went hungry also were more likely to report using cocaine prior to sex, using alcohol prior to sex, using heroin prior to sex, and also, just like our patients, were more likely to pay for or be paid for sex. And so, again, it kind of confirmed the hypothesis the patients were saying, and again, really cross-sectional pilot data with all the caveats that is the first study that looked at food insecurity among people that had returned from prison. And so, again, there were real trade-offs here. So, again, really time-consuming, hiring, paying, retaining these community research assistants was incredibly difficult. But it was important to establish content, validity of the surveys. Again, our participation rates, almost no one turned us down. And so there's a lot of external validity, at least for the convenient sample that we have. And then again, it enhanced dissemination. So, almost immediately, this was picked up in the New York Times. Barbara Lee is tweeting about it. And this isn't stuff that I did. It's the stuff that all of us or none did. Inevitably, every single time a state actually bans the food stamp ban, and now we're only down, at the time there were still 10 plus states that had a lifetime ban, now we're down to 1. I get called and interviewed, and I'll team from all of us or none of the people that are kind of getting the press excited about this work locally. And so West Virginia last time was the last state that banned it. So it's incredibly important. I think that the stakes are much higher. It's important to me and my patients, but who it's really important to are this kind of community of leaders that have gotten to know and respect over time, and they move the work out of kind of a PubMed linked, who's ever going to read it, journal, back into kind of a space that actually matters. And then lastly, so we've worked really closely now with designing a data sharing platform with our patient input. And so as I alluded to before with the Healthcare Innovation Award, we were able to design a cohort study of about 750 people that had returned home from prison. And importantly, we wanted to share that data with all the participants that had taken part in the study. And, you could say, oh yeah, we share it here, call me anytime, which is ridiculous, no one's gonna do that. Or really think about kind of what are the real barriers, how would people want to access data, are people even interested, all these were questions. And so what we did was, again, brought together a team of people with histories of incarceration, had them design a web-based platform that could do descriptive analyses, like with the touch of a button, do bivariate analyses where people could actually start to generate hypotheses. And it was fascinating. I mean, I will say people were really interested in their own data and really interested in how their data compares to the group. And so really pushed off, at least in this project was funded by Corey, really pushed up against the notion that those people don't care about their data. They certainly care about their data. were really in there asking us about this, trying to figure out kind of understanding confidentiality, understanding kind of what written analysis was. It was really an amazing experience. And so we have done this in a couple of different ways, but are now focused on bringing together patients, policymakers, researchers, and clinicians all together to collectively generate hypotheses. And so this data sharing platform is a way that we think maybe starts to kind of undo a little bit of the hierarchy in research science of saying, look, you can look at your data, here it is. People can test hypotheses that they're saying. Patients will say, like, well, what about this? Like that woman with, who came in starting to engage in sex work, and she's food disorder. You could test that. She could look at that. She could click these buttons. I've just noticed that this is happening. Let's see if this is the case. And so we've started to work with this to see how the platform can work, and now I'm really committed to doing this for all the studies that we're running in our lab. We're about to kick off an 800-person randomized controlled trial, and I will embed this certainly in it. It's just that all the data, any of the data have to be shared, not just research investigators, which we are already doing, but I think really importantly to participants and enable a way for them to digest. All right. So hopefully I have, in 50 minutes, I rarely talk about this long. So in 15 minutes, I've made the argument that this is a wide and expansive population of individuals that are currently under the criminal justice system, and many of whom are in the community, many of them who are currently incarcerated, but almost all will be back in our own communities. And these individuals have significant health risks that I think are distinctly unique and have been impacted by the criminal justice system. Again, I think that we're in this tremendous time where it doesn't matter what your political persuasion is, where you are, most people really in the U.S. are at least in agreement that mass incarceration has failed. Criminal justice policies as they exist now are not working, and what motivates you to that conversation is unique. Sometimes it's a conversation about cost, other times it's about kind of what is a human right or morality, but we're in a place where actively engaged in this country in conversations of criminal justice reform. And to me, what's critical, at least in the work that we've done, is that people with histories of incarceration have to be at the table, front and center, able to really participate equitably. And what it means is not just like one person on the speaker stage talking, but in a space where you're talking honestly about what does it mean when you get a huge NIH grant and millions are coming into Yale and X percentage, 10% is only going into hiring people with histories of incarceration, for instance. What does it mean when our communities will support certain policies for nonviolent offenders, right? But the truth is to decarcerate our country, what it means is that we really kind of tackle much harder conversations in mixed or not mixed companies about what it means when a person has been convicted of a violent crime. The vast majority of people incarcerated have been at this point convicted of violent crime. And so to me, it's this space that's the most important, is that insofar as we are all able to get out of our own silos and shells and really interact with more people that have been directly impacted, it's at least grown me significantly. And so just some small tips or large, first I'll start with, how many of you guys have ever stepped into your local jail or prison, Tompkins? Right? It's worth doing. So I'll say that might be the first step. Just go in, see what it's like. That to me, I remember when I first started visiting San Quentin, it was mind-blowing. And to me, especially in the meeting women that were incarcerated in the North Carolina corrections, it just kind of was transformative. So I'd say visit. Those of you that are doing research, running research, to start thinking about how it is that you can bring community more authentically into your work. For me, it's been creating a community advisory board, talking about our values, setting the tone. They've been with me through the course of my career. That there have been some ups and downs. They've been part of that, and they're really able to see that We pursue this not always perfectly, there's conflict, that's natural, but this is kind of a path forward. We've worked aggressively at training people with histories of incarceration to participate in research. And again, it can mean some small thing of like training, people to administer surveys. Like I've worked really closely with a handful of researchers at Yale to say, stop going to Yale undergrads. No offense to Cornell undergrads here. And let's train people that live in the community to actually have these skills. And so this has been important for us of really working on training people with histories of incarceration. I believe in sharing data back with the participants, being really kind of honest with yourself about what it means to share. Doesn't mean you just throw it up on, an LLM's website and hope someone can do it. And then I think importantly, what we've pushed towards in our own work is really starting to move towards using an assets-based framework. Is that when the research questions are designed, if you're always just looking at individual level variables without looking at structural kind of factors, it implies that the problem lies in the individual that's been incarcerated, not the policies and structures and systems that really play a large role. And so we shifted our work really exclusively trying to either focus only on assets and then always explicitly looking at structures. And then lastly, I think it's important is to really eliminate employment barriers, that in order to kind of have robust partnerships with people with histories of incarceration working alongside me at Yale, it means that there have to be no boxes when people check, an actual written working policy about who Yale hires with criminal records, and we've worked hard to do so. And so I end here. This is kind of an old picture of our transitions clinic network that's really grown. Really kind of the most strong argument for me is that this is the work that's brought me the most joy. I think like to be in a career this long and then really to see it forward, there has to be a real place of joy. And so I'm honored every day to be working with these people. It's what drives me, keeps me up going when you have yet another report to turn in or another IRD to submit. It's these folks that keep me going. So with that, I thank you for your attention and time.
Time for a few questions.
This was truly excellent. Thank you so much. I'm wondering how this has worked, if you've seen this happen in a rural setting. So I'm thinking about the interesting difference of a place like Tompkins County versus Hartford or San Francisco, wherever. And if you could talk a little bit about the urban-rural aspect.
That's so one of the places, and I actually didn't mention this, I had the pleasure of meeting with Aaron earlier, but our team is recently really interested in thinking about the differences in rural counties, rural places, as opposed to urban. And I'll speak to it this way, which is we've aggressively tried to bring in rural communities into a transitions clinic network, and it's just inevitably harder. A partnership that we tried and are still trying is within the Navajo Nation. And interest, and that has kind of difficulties that aren't just about rurality, but also ones around stigma and kind of the how the criminal justice system operates. So the short answer to that is we haven't done as much. One of the things that, there's a student that's working in our lab and in our team right now, and we're really focused on looking at openings and closures of jails and prisons, especially looking at rural settings. So some of the work that we're focusing on now is moving beyond kind of individual impacts and really looking at kind of the community. So, there's serious implications because incarceration rates actually are going up in rural communities, and there are real economic and kind of community development questions that should be answered and health questions of that. So, no, I haven't, but I'm really very interested. Yeah.
Great. Thank you.
Do you have is there research done or any kind of figure on the economic difference of if somebody comes to one of the transition clinics, like the cost that's kind of saved? Because I can imagine an argument against this would be like, why do we want to throw money at people who are incarcerated?
Yeah.
Trying to understand, well, if you spent X dollars, how much it would save the community.
Yeah.
Is there anything like that?
Yeah, so we have, I didn't show these data, but we have a paper that we just published in BMJ Open that looks at criminal justice involvement among, so the propensity match study, so pretty well matched, I'd say, but quasi-experimental, so at that. and where we found that there were no differences in, and actually we haven't reported on the cost yet, but there were no differences in cost to Medicaid. So in fact, the costs were equal on both groups and maybe even a little higher in transitions, but not statistically different. One of the big reasons that we thought that they were statistically different is because it's not statistically different, but higher, sorry, stating, is that we, within our network, we're really aggressive for treating hepatitis C. So that just costs more, pharmacy costs, but where we did find a difference was the cost of the criminal justice system. So a sizable savings. We showed fewer days, about 26 fewer days in jail among those that were in transition clinic program, and then fewer parole or probation revocation, so just fewer times in at all. And so it's a significant cost savings to corrections. And so that's, I started hinting at this, but those data have moved forward from states like North Carolina to start kind of shifting their dollars out of the correctional system and into the health system because we're seeing kind of decrease in going back in. But it's interesting, that is the argument, right, that speaks to, state policymakers. I think it's an important one. But, we talked to a lot of state legislators and then in particular Medicaid managed care organizations. And the hard thing is that, again, when you provide costs to a population and they're newly engaged in community care, I mean, the Oregon experiment, all sorts of experiments have shown that the costs increase. So we have, debated a lot about whether or not to really kind of push forward on that because these things cost, and especially the costs are saved, I think, are one, the community costs, hopefully generational costs that, when my kids are 40, that they'll see fewer people in their community that are incarcerated, and those costs are borne out not in the 1 year increment that we're studying. Mm-hmm. But we only see decreases in costs in 12 months. And it's all from the Department of Corrections side. So it's a good state level hook, but it's not great for Medicaid managed care organizations.
Last question.
Yeah. What?
Last one.
Oh, okay.
I wondered if you could speak a little bit about the way in which the transitions clinic model incorporates referrals to community-based organizations in order to improve health outcomes.
Great. So, it's interesting. I'm trying to think of kind of variants across the site. So it really depends on, so each transitions clinic program is, designed, understand, they're based within community health centers. They're not like standalone clinics. And so they're really impacted by the healthcare culture in that city and then also the criminal justice culture. So I'll put that forward. Most settings have a reentry council. Many actually have a reentry council. And we have found that those are kind of important referrals. And the reason is because there are so many laws on the books, programs that don't see people with histories of incarceration. Even if it isn't written, it's the practice. And so it's really important to only refer to programs that know how to take care of people with histories of incarceration. So the reentry councils have been an important place for us of identifying the right programs. There's like a bajillion programs in New England. I mean, and in many of these cities, there's a program for this and that and this, and then you realize there's this problem here, and then they don't want to see those sorts of people, or actually they're really disrespectful. And so what we do is really try to have our community health workers be good consumers, really try out the programs first, build relationships, and those are the ways that we worked it out. The other thing too is that, I didn't present these data, but there's a lot of turnover in community organizations. There's lots of turnover in the Department of Corrections. So once you've made a relationship, it lasts for 3 months, and then you're back at it. And so we're really active about building the right sorts of relationships. And you would think at this day and age, like things should be automated, right? Like you would know, and this is how it is, but it's really relational. So it's about finding the right community health worker that then can find the right organizations that really can help our patients prioritize their own preferences, needs, and values. Like it's not recreating the criminal justice system, but really saying like, you're home, let's do this together. Yeah.